Welcome, my name is Amyn Haji. I'm one of the colorectal surgeons and interventional endoscopists at King's College Hospital in London. Thank you for your interest in our paper, which looks at a multimodal assessment of rectal polyps prior to treatment. I think it's really important to manage rectal polyps in a slightly different fashion than all other colorectal lesions, because decision making is crucial in order to identify patients that may harbor invasive disease, as the wrong treatment for these patients can subject them to quite radical surgery, which is unnecessary. And we know that rectal cancer surgery, and indeed even surgery for benign rectal polyps, can have a lot of comorbidity associated with them, in particular patients that need low anterior resection or abdominal perineal resection. So therefore, in our practice, we take great care in assessing all polyps, but in particular for those that have rectal lesions. And what we would normally do is all polyps that are referred in the rectum, they would have multimodal assessment in a standardized fashion. These patients would have magnification endoscopy, and we typically use 80 to 135 times zoom, using indigo carmine and crystal violet on occasion to look at kudo pit pattern to identify the endoscopic diagnosis. In addition to this, we would use spectral imaging using magnification MBI, and using the two modalities come to a decision regarding the endoscopic diagnosis. It is also equally important to identify lesions according to Paris classification, because we know that patients with certain types of Paris classifications, in particular lateral spreading tumors of different classifications, whether it's being granular or non-granular, will harbor invasive disease at different rates. In addition to this, we have introduced in our practice using high frequency mini probe ultrasound in addition to magnification endoscopy. We used to use it for all patients initially, but now we use it selectively, as we know that magnification endoscopy for large nodular components where they have rectal polyps is not as accurate and the sensitivity is low, and therefore high frequency ultrasound is used to ensure that these patients don't have deeper invasive cancer or indeed involving the muscularis propria. And I think in this fashion, what we've been able to show is identify patients that are suitable for local excision. And in that case, we would primarily do endoscopic submucosal dissection, giving the pathologist a single specimen so that they can identify areas of invasion accurately rather than doing piecemeal resection. In this fashion, we've been able to offer treatment with local excision to a high quality in all patients with benign disease. And in addition to that, we've been able to identify patients with invasive disease that have had early submucosal invasion and have received en bloc resection. And equally identify those patients that are not suitable for local excision, and patients go on to have more invasive treatments such as a laparoscopic low anterior resection. So I hope you've enjoyed the paper, and thank you for your time.